Good morning, Barry.
Hey, Mark. Hope you had
So,
a nice holiday.
yeah, I have, and it's still moving on. And I'm glad that we're continuing through the holidays to have our podcast. I think it's important to have our weekly podcasts to talk about Airway, right? So, um, for all you newcomers to our podcast, I'm Mark Cruz, and my teaching partner, Barry Raphael, and
Hey,
our
everyone.
third colleague, Rich Stevenson's taking some time off with his smart man, with his wife, spending some quality time. So good for him. We'll see him in one of the next podcasts. But Barry, today it's our show to talk about our topic of the day. And let's talk about where the airway problem starts. And of course, the argument about the chicken and the egg um, comes into play here, doesn't it? Like, when does it really start? So, we had the intent of having a guest come on who's one of the authors of one of the chapters of our textbook, and that's Kevin Boyd. We were talking to him last week and kind of reviewing his chapter and some of the concepts. And I think it's going to be a very important chapter in our book, but for some reason couldn't make it today. So you and I'll kind of talk a little bit about that. And so with that said, any thoughts, Barry?
Yeah, so we generally think that the airway problem starts with the first breath. But what Kevin's been showing us, and is really fascinating, in fact, we've learned about this in some of the other coursework that you and I have taken, is that there are precursors to airway problems in utero. So even before the child gets born, there's certain influences that are other than just purely genetic that will affect facial growth, skeletal projection, airway size limitations, so forth that happen before birth. So this is extending our view of things and giving us even more control over what happens by paying a little more attention to mama as she's cooking the baby
Yeah,
there. And
yeah, I'll go back as I'm listening to you, Barry, and I remember that as one of the speakers for the first ADA Airway Summit back in the day, right, which was the following day after we were in that conference room in the ADA talking about, well, what is dentistry's role in this as a result pursuant to the 2016 resolution on airway and airway screening. And then the next day we had our first conference on that. ADA, and the ADA was kind of lukewarm about it, if you remember, but it was because it was sold out days before. I mean, it was very quickly it sold out, and then they decided to have a second and a third, etc. So it launched that whole awareness campaign. If you will, I
Mhm.
remember I was one of the speakers, and in my talk, I actually did address the where it started during that beginning of the third trimester of life. There were studies, fetal ecography studies, that actually showed that at the beginning of the third trimester of the pregnancy, and Kristen Guilleminault is really the person who cited this, that the fetus was beginning to swallow the amniotic fluid at, it was, I think, something like 7 milliliters of amniotic fluid at a rate. I think the unit of time was per hour, let's just say, and that by the end of that trimester prior to birth, that fetus was sucking up 500 milliliters per hour. So it escalated. And so Guilleminault talked a little bit about what was going on there. Well, number one, it was just finishing the growth and development of the airway and the face and the facial skeleton, but it's also starting to program the nascent neurology of the infant that armed the brain with these fetal reflexes in preparation from transitioning from um, fetal respiration, if you will, to respiring atmospheric oxygen. And so that function of the three things that we talk about, structure, function, and breathing behavior, is manifest in that whole statement there. So yeah, what do we do with that information? Or um, for us, if you remember, the Airway Collaborative actually launched a fetal maternal initiative, which I also mentioned in that lecture about we should really be talking to the OBGYNs and to the moms about what to do during birth to obviate the well documented problems in pregnancy because, as Stephen Park would say, citing the studies, that almost all moms have sleep disordered breathing by the end of their pregnancy. And of course, it makes sense, right? Because you've got this big
Right.
fetus that's getting in the way of the diaphragm moving. And so moms are very uncomfortable. They're sleeping by themselves and they're finding pillows to hold on to that. But as it turns out, their downstream consequences, upregulated cortisol and stress hormones that the fetus is actually exposed to. So that results in small for gestational age, um, increased risk for preeclampsia, increased risk for gestational diabetes, and all these other things as a result of moms inability to breathe properly while she's sleeping. And this information that we're going to talk about, the inferior facial angle, and we'll share our screening with that Kevin's writing about in this chapter comes to the fore because what do we do now with a fetus that has an underdeveloped facial skeleton? Well, what do we do? First of all, it's not recognized. So that's what we're going to talk about.
Yeah. Yeah, we've been thinking if the craniofacial deficiencies start at birth, that it has a lot to do with the first breath and then feeding and breastfeeding and tongue tie and whatnot. But there are these major influences that affect skeletal growth. In utero, you mentioned maternal hypoxia. And we've been talking for a while about how mothers need support during that third trimester. You know, CPAP unfortunately maybe has a bad reputation. It's certainly not a sexy thing to wear to bed at night. It has its limitations and all that, and people don't want to get into it because it just isn't socially, acceptable. But with the work that we've done, we've shown people that CPAP does not have to be a life sentence, even though it's one of those things that medicine considers the gold standard. And unfortunately, they've been loath to pick up on other solutions. Why not CPAP for a third trimester for mom who's suffering from that intermittent hypoxia, if not frank sleep apnea, to help not only her get better oxygen, but help the fetus and the baby get better oxygenation. A reduction in stress hormones, um, which are, you know, I mean, there's so many stressors on a pregnant mom, uh, in both physically and mentally, especially if they've not been through it before. It is it's a kind of a novel experience that makes a lot of people nervous. Endocrine disruption is a big thing, and we um, we look at the endocrine disruptors after birth all through age, and the endocrine cycles in pregnancy are even more dramatic. Um, we look at inflammation in children and adults, but moms can be carrying inflammation that affects facial growth. There's some ideas that there are the kinds of fusion anomalies like cleft palate and so forth that may be linked to inflammation.
So, so
And
let me just so let me just say that I would argue, and you and I have talked about this in our mini residency, and when we talk about the topic, is that part of the problem is it's not so much anyone's fault as much as the reality that in an allopathic healthcare system, it's the way we see the problems are really managing a downstream consequence because now there's symptoms or there's some problem. And there's very little incentive or training to really ask that question why looking upstream, right? We just want to deal with the sign or the symptom that comes up. And when you start really taking a physiologic understanding of the problem, the answer typically is there, right? It's that, like you just mentioned about, we don't think about the endocrine aspect of the problem. And if you look at the history of craniofacial growth and development concepts, it was the in the 70s, it was that added hormonal layer that affected growth and development that started changing even the functional hypothesis, matrix hypothesis,
right,
that there's some other things going on that we're not seeing. And both Ron Harper and Yoon Pei from University of Maryland, he was at UCLA prior, did show that the infant, even having short bouts of chronic of periodic breathing, which would result in this chronic intermittent hypoxia, had unexpected results in facial bone growth. They found that the bone was more fragile, they were more elastic during a very critical period of growth and development as a result of how you're breathing. And you just don't connect those dots because that's physiology. And so, in summary, I think that we tend to think of the problems more mechanically and less physiologically, lack this appreciation of a lot of the things that are happening at the cellular level, the molecular level. You mentioned the inflammation in the form of cytokines that actually result in a lot of problems. And so that's where we have to really go back and see and ask different questions.
yeah, it gets down to that nature nurture debate that frankly has been running rampant even in orthodontics for 100 years, pendulum swinging back and forth. And we're very much on the side of nurture of the epigenetic influences that have affected humans really for at least several hundred years, and it seems to be a problem that's getting worse and worse. We would think that in utero growth is entirely genetic, but it really is not. That there are all these influences that are occurring to the facial skeleton way before birth. It really is something that we can have some influence on because I mean, there's certainly genetic influences. I don't, I say
Well,
this to people all the time that our kids look like us. We look like our parents. There are things that are passed down through the family, but as we know, they're not necessarily built into the genome itself, but they're being expressed because of editing of the genome or expression of the genome that's influenced by these environmental factors. So for us to be able to start determining some of those things early on, even before birth, really is pretty remarkable. I've been
yeah.
joking. I'm sorry. Because I have this slide that I've been showing for some time that I kind of made up. It was of intrauterine surgery showing a uterus and a little hand sticking out of it. I put a little retainer in its hand and a light wire plier in the other hand, as if we're going to be able to do prenatal orthodontics. And yet, what we're starting to see is, in a way, there can be if we start addressing some of these early things for mom.
Well, let me just say what you just described is a representation of what I was just saying is how we think, right? Like as if, and maybe it would be important, Barry, to make this distinction between genetics and epigenetics because this is where the confusion comes in, right? So what happens is the base pairs that determine the allele, the genetics, if you will, the DNA,
Yeah,
is really we were led to believe for so long that that's really the determinant of disease expression and et cetera, et cetera. But what's been
right.
found out, and that you can't really change it. You change it through mutations, and those mutations through natural selection change over thousands of years, tens of thousands of years, very, very slowly, right? That
Yeah,
makes
right,
sense.
right, right.
So, and yet, if you say, well, Junior looks like dad, that looks like grandfather, looks like great grandfather, it's very easy to say, wow, yeah, it must be genetic because they look the same. And with epigenetics, we have to understand what that is. What epigenetics is more is the effect of the environment that influences those base pairs and those alleles and how they behave
How they
through
get
what are
expressed.
what are called like two basic strategies. One is a pre-transcriptional methylation and post-translational acetylation. And what that means is that if, let's say, you eat a certain food that's high in methyl groups, that what that will do with certain in certain circumstances, it'll cause the DNA to unravel the histone proteins that are wrapped very in an organized, compact way to unravel, to open up that segment of the DNA where the
For expression.
alleles are, and now they can express. So it upregulates the expression of a particular gene, or it can have the opposite. It downregulates, it causes it to. So, what we're finding out is that those methylation patterns and acetylation patterns can actually be passed on from mom to up to 100 years later. So, you could see how you could think it's genetic because it could influence multiple generations. And of course, wouldn't it make sense that it is the DNA? And as it turns out, it's not. It's the environmental risk factor. So there are classic examples like the Dutch winter harvest, um, groups in the Arctic that, another example are groups in the Arctic that would be isolated and their food supply would oscillate, and that had an effect on obesity. And there's the agouti
Right,
gene. There are many examples of what we now understand as epigenetics, which is a short way, Latin above the gene, but it's a short way of saying that the
right,
environmental inputs, as it turns out, are key. And the good news from that means that we can change expression. There are some things that we can
right,
do, and that really when we recognize that earlier on, we are empowered to try to intervene to prevent disease or dysfunction expression. And so the downside of that maybe is that it puts a greater responsibility on the provider and the patient, which oftentimes in our allopathic system, we want to factor those things out because they can't
right,
take a pill 4 times a day because they forget, or they won't exercise the amount, or they won't, they want a magic pill or a surgery or whatever the case may be. And so that's a different philosophical discussion, but in
mhm,
summary, the good news and the bad news is good news is that we could change it. Bad news, it puts a little bit more responsibility on this. But I think this generation of this population is frustrated with the current disease management model, and they're coming to us saying, what can we do for my next child? And that's really very rewarding. And we, of course,
right,
we talk about that in the mini residency. There's so many things that the dental provider can do in addressing structure, function, behavior
Yep.
early on to change the expression and optimize expression of the phenotype. So,
Yeah, yeah. Yeah, it's incredibly empowering. And it's not the easy way to do dentistry. It's not the easy way to do orthodontics for sure. And it does signal a very different approach to healthcare and and has with it the promise or the potential for us solving things long term. In other words, we've created these familial epigenetic characteristics that get passed down because of many generations of living in this wonderful modern world, right? And it's a problem that seems to be getting worse. When I was in my orthodontic residency, 50% of kids had crooked teeth. Now it's 80% of kids have crooked teeth. Have our genes really changed? I mean, at this point, I don't even think there's such a thing as genes for crooked teeth. And the crooked teeth are the least of it. You know, we say that they're the canary in the coal mine. The real problem is that our physiology is not able to work as well because of these changes. And that when you extrapolate it a little bit, it's an existential threat because children's health is worsening. They're getting to the point where they're not resilient. They're, in many cases, neuroatypical. It's going to be very difficult for them to mature. It's going to be very difficult for them to find a good job, to mate, to be resilient enough to be a parent and bring up kids that who them they themselves will be able to have kids and so forth. And, we knew this argument very early on, and yet the more we learn about the influences that we can have, the more empowered we feel to bring our species out of this conundrum, out of this negative cycle of development and growth. And yes, maybe it's going to take several generations of a change in thinking to get us back to where we have to be. And and then relating this to the prenatal aspect, it's really fascinating. You know,
well,
it
I'll
yeah,
say that I think having said all that, Barry, that part of the problem is that the concepts that we're talking about are not new, but they just don't translate into clinical practice. So people like Paul Ehrlich, Stanford, Richard Klein, probably the world authority on facial skeleton growth. Robert Corcini wrote a book about this. Uh,
Daniel Lieberman.
Daniel Lieberman wrote the book The Story of the Human Body, and so the data is out there, but it's not clinical. And if you're
Yeah,
a provider, I'm thinking someone listening to the podcast might do this eye roll and saying, "Wait a second, you're taking away my way of doing a living." Relax. The problem is still present. There's enough people that
yeah,
need help to fix it, but we should be taking concrete steps of educating healthcare and the public, which is what this podcast is all about, to really start changing the inflection, if you will, on the future public's health. And maybe with that, I'll share the screen on this chapter that will be in our textbook that I give credit to Kevin Boyd about for coming up with this idea of if, I don't know if you could see that well enough here. Can you see it? Is it
yeah.
sized well enough?
Craniofacial respiratory complex.
Right. And so he talks about how we don't think about the oral cavity. We don't think about our face per se as part of this complex respiratory system, but everything is connected. The eustachian tubes, the palate, the nasal fossa, the lips and the tongue, and that ultimately some of the big risk factors in having problems are manifest if you know how to read the tea leaves, if you will, on these facial growth patterns very early in development. So
That's right.
I think, I think that's really a key concept to start really understanding is that these things are important. So I'm going to stop the share here.
Yeah. And
Um,
remember, that's the anterior portion of the airway. The craniocervical complex, the posterior section of the airway, just as highly influenced. That functional space in between is really how we're breathing, and it is changing.
no question,
Yeah,
no question, and so we could. One of the things that he's talked about that he's been looking at as well is this whole idea of the mandible being the kids being born
right,
with such a diminished mandible, and that potentially there is nothing that could be done about it if you catch it late in the game, which is mostly what the orthodontist is seeing when the kid's already 7 years old. It's late if you have
yeah,
this retrusive mandible, if you will. So I think it behooves us to really start intercepting this problem much earlier in growth and development, if you will.
right. Yeah, the conversation started when Kevin started showing us the sonograms, which are a way of looking at the fetal skeleton. Um, and it's a little hard because with a sonogram, it's a little harder to position the baby's head to get a true profile view. I I've have some recent experience with that. My daughter is a sonographer, and we've been meeting my grandson to be. And I said, look, get me a picture of of his profile. And it's difficult because sometimes the baby is positioned in the part of the uterus where it may not be easy to see that, and there's no cephalostat that we can use in utero to position the baby's head properly. But if you can get as close to a good profile shot as possible, this this illustration that you're showing is a way of defining the position of the mandible in relationship to the cranial base. They're
Yeah.
using the anterior portion of the frontal bone, as a reference line, perpendicular to that to measure the facial angle, inferior facial angle from the chin to the upper lip to the intersection with that reference line.
And and
And
and,
well,
and Kevin had actually cited this data was already out there,
mm,
and so when you start understanding that, and you could see this early on, when the child is born, there are steps that you could take for expressing more full development of the mandible. And so he talked about the sonograms that he was looking at and comparing it to fetal skulls from hundreds of years ago that he had access to. And there weren't a lot of them. There weren't a lot of them. But what he found is that the mandible in those fetuses, they weren't still born, but they were actual skulls the mandibles were much wider, they were much longer, closer to matching the nasomaxillary complex or the maxillary arch. And so that's kind of what piqued. He started saying, wait, this looks very different from what we're seeing now. So we see things like everyone's aware that autism is increasing, peanut allergies are increasing, all these other disease markers that were rare or didn't exist before, that if you look upstream, you're starting to see some changes in the facial skeleton in the birth process, how we're born, again, going back to epigenetics, that may
Yeah.
be what the problem is. And the answer is that more modern techniques, if you will, in surgical intervention and medications, yes, they can help, but maybe to first recognize the problem and what can we do to alter expression of the individual once they're born.
Hmm.
And that's what we do, right? We look at it and that's what BioBlock Orthotropics does. It's not
Right.
easy therapy, but what you're doing is you're changing the genic input with a habit appliance that stimulates condylar growth and fuller expression of the mandible. And of course, the typical orthodontist doesn't want to really deal with that. They want to just slap on braces and just straighten them out because that's very easy to see. And yet, the straight teeth are not really a marker for beauty, aesthetics, and health. I mean, we've been kind of think that it is because we don't want to see them.
Right.
And so I think that's part of the problem as
Yeah,
well.
that's right.
It's a much deeper problem because those,
But let's get back to this diagram because we've really not had a way of phenotyping a a preborn baby. There's really been no measure of that. Um, we know that preemies, for instance, will often have high narrow palates, but we can't really see that in utero. This is one metric, maybe the first for craniofacial growth, where we can actually start studying the difference between someone that has less than a 60-degree facial angle, pre-birth, and what they look like afterwards. Babies often they're born and they look like they have no chins, or it's kind of tucked back. And how much of a problem is that? I mean, we've always assumed that they're going to outgrow it. But now we know that growth can be stunted very early on in life, that narrow palates and retrusive mandibles can be a feature that's a risk factor, right? That study that Guilleminault did looking at 7 consecutive fetal death, not
yeah.
early natal deaths.
Oh, yeah. Palate
That
overall.
right, the high palatal vault, the trouble with respiration, the I don't know if he mentioned mandibular retrognathia
No, no,
there,
he
but
didn't. He didn't,
it
but
is that same facial pattern, right?
so we always talk about the face in three dimensions of space, right? And we
Right.
teach that when we're actually phenotyping. So you just saw that one illustration was a mid-sagittal view of the problem, but that's only one dimension. So that's the x-axis, if you will.
Yeah.
And the y-axis of the verticality, that's another one we talk about. And then there's the z-axis, right? And so there are other studies from other areas in healthcare that actually look not that also look at the transverse as it pertains to the nasomaxillary complex. Where, and I was mentioning that to Kevin last week when we are talking all about this, that you're looking at the mid-sagittal with that image. But when we look at it transverse on a very young infant or preborn child, as you were saying, that it's pathognomonic if you see a nasal aperture that is what's called the piriform aperture. If it's less than 11 millimeters in transverse width, it almost requires emergency surgery to enlarge that nasal airway because they're supposed to breathe through the nose, kind of like going back to Harville's monkeys where you plug them up, that child will be in distress. Okay, so that's maybe an exaggerated iteration of the problem, but you could have someone that maybe it's at 13 millimeters piriform aperture that they are in distress, but they're able to get through. And what Guilleminault found in those babies that were born and died in Paris, he did talk about palate ovale, but interestingly, he also in the autopsy material you could see Waldeyer's ring was swollen, the tonsils were already swollen, and of course Stupak and Park wrote a paper called with coining the term the musculoskeletal hypothesis, looking at 100 years about arguing about removal or non-removal of tonsils, that where the problem started was very, very early on, and that the antecedent to the problem was this swollen lymphatic tissue, not because of a non-specific infection, but because there was too much flow um, limitation that caused turbulent airflow and
Right.
caused those tissues to become enlarged, choking off the baby, right? So that's where the egg, if you will, before it turns into a chicken, starts during fetal growth. Obviously, they're born in those first critical days, even that are certainly important. And we know that if a baby has suffered through meconium inspiration or aspiration during the birth process, that child's in an emergency situation until they clear that airway. But a lot of kids don't express that per se, but they're just already behind the eight ball. And as the DOHAD community, Developmental Origins of Health and Disease, have said, the studies are very clear that the first 1,000 days of life largely determine life expectancy and risk for acquiring chronic disease. So that's roughly from
Right.
implantation to the end of the second year of life.
That's
And
right.
us dental providers are coming in way later than that, right?
Way later than that. Yeah.
And so that therein lies a lot of the problems, and we're just not recognizing that it's normal because we're seeing everybody having these problems. And so now we're starting to talk about that.
Yeah. Yeah. I mean, the first 9 months of the 1,000 days is, before birth. And there's so many things that can be done to help support mom, and some of them have become popular subjects in the culture, like maternal nutrition and getting a good night's sleep and so forth. But um, even the position of the baby in the uterus and the birthing process, that can put tremendous amount of strain on these very malleable plastic bones that with large sutures and fontanelles that can be distorted and bent. There's a physiologic process to it, but there's also, as you can imagine, an over an excess of pressures, the constant pressures against pelvic bones that are smaller, or prolonged labor, which is getting more and more difficult. Those bones are being affected in that way too.
So, and talk about epigenetics, think about it's just an easy concept to understand the difference between natural birth and a C-section, that we know that mom's flora is so important epigenetically,
Yeah.
not just the colostrum, but the flora that coats the baby actually turns on a lot of switches, upregulates a lot of switches as a result of that. And when you're a C-section, uh, that may be required for all the reasons that you just described to have a live birth, if you will, obviates the benefit of that mama's flora that is being recognized, that they're now taking mom's flora and coding that C-section baby to kind of deal with some of these things. So that's an epigenetic manifestation right there, a switch, if you will. So yeah, there's a lot of complexity here that flies in the face of allopathic mindsets of how we see the problem. And so I like to always say that it's not anyone's fault. It's just the way we're understanding the problem, how we're educated. And we oftentimes get that propedeutic education, that education that gets us ready for specialized training that we ignore, that really is where the answer is that we really need to look at the problem more physiologically. And the sleep and language pathologists would say that when they have a 5-year-old kid as a referral, that kid's a geriatric patient for them already.
Mhm.
Because they're seeing those kids the first year of life, second, third year of life, and what they're looking for are those well-documented markers in function. So the horizontal chewing pattern has to be replaced by a transverse stroke by, say, month 12. And if it's not, they're already behind the eight ball. Maybe there's some soft tissue problem. It could be ankylosing. It could be any of a number of things along the hyomandibular kinetic chain that they're trained to look at and repattern and recognize that once the tongue crosses the midline, that means that their neurology is maturing towards a mature swallow that's replacing that hooker reflex and that infantile reflexes that were so important right when they're born
Right.
that need to be replaced. So then
Yeah.
when we're seeing them with a tongue thrust that now is causing havoc with facial growth, and that you can't straighten out teeth until you take care of that problem, uh, you start appreciating the importance of structure, function, behavior, going back to the sleep and language pathologists or myofunctional therapists that are
Yeah.
trained in this, is that they need to tackle this problem very early on in getting that function to help with proper growth and development. Things that Garliner was excoriated for and exiled because he
Yeah.
said, how can you even think about that? It has nothing to do with what we're doing. And now we know that it is important. Brian Palmer is another one that contributed to our knowledge base. And of course, Kristen Guilleminault knew about all this stuff. And even he, as a seat physician, was sometimes challenged within his own community, academic community. And so this is what humans will do, human behaviors. I think in closing this segment before we end with our, learning moment of the week, we need to just have a little bit more humility and give each other more opportunity to talk about the problem, be open to these problems. And I've always found that the most intelligent, most educated individuals are much more open to listening to concepts, to think about something they may not have thought about. Whereas those that are very dogmatic, that know much less, are much more eye rolling and saying you're wrong. It's the first thing that comes out of their mouth because it it maybe contradicts what they believed.
Yeah.
And to me, I see that as a red marker of someone who doesn't really understand the problem wholly. And I've learned it the hard way, right? Because I was there
We
too,
all have.
right? And the more you immerse yourself as you get more people thinking differently, the more you realize that that low resolution image starts becoming higher resolution as we put in more pixels.
Yeah.
And we allow that to happen. So I'll end with that. And any closing comments before we get to our.
Yeah, sure. It has to do with the way medicine is siloed, in that we tend to look at specific symptoms or pathologies, perhaps, and not connect them to the things that pre the precursors and the downstream effects of them. One of the things that we concentrated on from the very beginning in the AMR was the timeline, because, and we said that dentistry had gotten involved in Airway through OSA, but when you start looking at the precursors to that, you realize that that's just a downstream effect of trouble breathing from birth. Now we're having this conversation about pre-birth. We're talking about the kinds of things that we can see that are often said that they will just resolve on their own. And in a way, they may appear to resolve on their own, but what we now know is they're just morphing into another kind of problem. The infantile reflexes is just a great example of that. That the transition that you make from an infantile reflex to a mature reflex, that can happen perfectly. It can not happen, or it can happen imperfectly, and the downstream effects of that can last a lifetime. And you may have somebody that's got poor physical coordination and trips and breaks an ankle, and has has bad knees many, many years later, where we didn't really, and you get, surgery, replace your knees, whatever it is. If we had taken care of reflex integration early on, that kind of thing might not have happened. So we're just becoming very aware of the chain of events. The chicken and egg is a spiral. It's not a one-time event. And there's almost no need to decide which one came first. It's which one is going to come next. And so we've got this form and function and behavior spiral that goes on and on and on throughout life. It's either headed towards better balance, better homeostasis, better equilibrium, better resiliency, or it's headed downhill towards
Chronic
patient
disease.
symptom and chronic disease. Right.
Yeah, and
Exactly
and
right.
and we're just not trained as healthcare providers in again in the West to see the problem as such. And so that therein lies the problem is that yes, the organism wants to live, wants to survive, so it will
Yeah.
struggle to get to perhaps be subclinical, right? Because we're looking at symptoms, it's subclinical, but it's just right below the waterline, if you will, before it expresses disease years down the line in another way.
Yeah.
So we're replacing one problem with another, and we could get into this in another podcast because as you're listening, and I'm listening to myself, people who don't really understand this way of thinking, maybe going, yeah, 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 they're because they're really very allopathic, they can't understand it. And
Mm.
that's where bioregulatory systems medicine is important, where you're recognizing things are happening parallel at three levels, the cellular level, the molecular level, and the tissue level. If you're just looking at the tissue level and you're not seeing expression of disease or the symptoms that you're going to treat, you're going to think everything is fine. But
Right.
underneath, the cytokines may be upregulated that are causing a problem in another organ system that's not even in your area. So, as an example,
Right.
that, let's say, manifests as metabolic dysregulation or cardiovascular remodeling, endothelial disorders, and things like that. So we'll leave it at that. And I think the learning moment for me, I was telling you in the green room before we started, I just got off a Zoom with my good friend, our good friend, Peter Litchfield, who really has helped us understand the breathing behavior piece of this. That again, allopathic medicine, even though it's been well trained in pulmonology in this concept of end-tidal CO2 and breathing mechanics, tends to ignore it, right? Because you're breathing. And so he's developed the capnometer software and the hardware. And he was telling me about the new capnometer looking at these gamers. So gaming is they're like, I don't know, it's a crazy number, 70 million, 700 million people worldwide that are in professional gaming. It's considered the largest
Oh,
sport around the world, even greater than soccer. And that they make a lot of money with that, and that they're actually looking at capnometry and tidal CO2 that affected their ability to game effectively better than their adversary, if you will. And the way they were looking at that is they would buy these very expensive mouse setups or keyboards that will change their reflexes from say um, 600 milliseconds down to 100 milliseconds. And that difference made the difference whether you were, winning or losing. And this one company found that there was that correlation that they're now looking at using capnometry to improve human performance. And of course, Peter has these very big contracts with the Department of Defense training, pilots, jet pilots, CIA,
hmm.
FBI agents that have to make millisecond decisions. Of course, we know that in sports,
Right.
that how you breathe really affects performance, right? We choked
On a moment to moment basis.
the moment to moment basis. So the learning moment for me was that conversation that he was telling me all about this and
Yeah.
that now it's exploding. And he had someone from the Department of Health in the UK, the health service in pulmonology, is now doing a study looking capnometry with kids because of in asthma. And what they found was that low end tidal CO2 was highly correlated with the incidence of asthma,
Sure.
and that it was not an allergen per se. And in fact, there were no markers, um, uh, no markers in those patients to show that they would have a high risk of asthma, and that they're finding out that it's actually the breathing behavior that's stimulating it. So the
That's
learning
right. It's
moment.
not true asthma, it's asthma symptoms.
Right. It's asthma symptoms that mimics it. And of course, we know
Yeah.
that because we talk about that in the airway mini residency with laryngeal pharyngeal reflux disorders that cause quote unquote asthma. So things are more complicated. That was my learning moment just right before we jumped on here.
Yeah.
And I found that fascinating. Any
Yeah.
comments before we close this podcast, Barry?
All right. Well, my learning moment was really as we were talking to Kevin, and it is a shame he can't be here, but looking closely at that diagram, the inferior facial angle. Now we're starting to be able to phenotype infants, and to the extent we can help mom give a good birth, that'll be helpful. But otherwise, it just reinforces that we have to hit the ground running when the babies are born. That we see a high narrow palate, we don't just take it for granted. And it's not something that they have, it's something that they're developing. And we can help that. And we can do that from birth onward.
Yeah, and I believe that
Exciting time.
it is. And I do believe, even though it hasn't really reached or penetrated yet, but I do believe that the answer to this higher incidence of autism and peanut allergies is in this milieu, this intellectual milieu.
Yeah, that's right.
It's not in the food supply per se, but it's in this milieu that's largely been ignored. But that's another podcast. Barry,
Great.
thanks for another hour, and look forward to our next podcast and with you and Rich. Have a great rest of your week, and we'll talk soon.
And have as good a second quarter of this century as the first one was.
Yep,
If we get to be this much smarter by the mid-century than we were at the beginning of the century, I think we'll be well on our way helping humans be better off than they are.
agree. All right. All right. Take care. I'll see you. Bye bye.
All right.